and welcome to the Home of Medicine podcast with me, Dr. Amie Burbridge. I'm a consultant in acute and general internal medicine working in the West Midlands in the United Kingdom. Now, this is such an exciting episode because we have a very new home for the Home of Medicine. And the new home is the Royal College of Physicians, Edinburgh. Over to you, Ben.
Thanks, Amy. Hi, Amy. Hi, everyone. My name's Ben Lovell. I am your co-host of the Home of Medicine podcast. I'm also an acute physician and I work in London in the UK. And I'm really excited that we now have a new home for the Home of Medicine. And I want to say, before we do our episode today, welcome any new listeners and a big thank you to the European Federation of Internal Medicine, which has been our home up till now for the Home of Medicine podcast. And they've really supported us over the years with this podcast and helped us grow it from a gleam in your eye to the really fun and hopefully educational podcast that it is today. So big thanks to Ethan for that.
Absolutely. Thank you, Ben. And you've got a case for me.
Are you ready?
Always.
Okay. So this is a case that I encountered on the Acute Medical Take and on the AMU a short while ago. And it is the case of a 63-year-old woman. And this woman presented to the Acute Medical Take with an acute confusional state. She is a tourist. She's visiting us from where she lives with her family in Japan. And she was doing a European trip. So she flew from Japan. She went to Paris a few days. Then she came to London 2 days ago. And this is a woman who doesn't speak any English. So she was there with her husband and with her 2 daughters, her grown-up daughters. And the translation headline was that she's normally very fit and well, but over the last 48 hours has developed intense confusion, a little bit of agitation, fearfulness, delusions that she is in trouble, that someone's coming to chase her. And now, as she sits in the AMU, is actually very, very difficult to calm down, is pacing around, is completely unlike her normal self. And she was seen by an emergency medicine doctor and by the liaison psychiatry team down in the emergency department, who said that this may be a new psychiatric presentation, or this could be an organic problem. However, she needs a further medical workup before we were to make this diagnosis. And now she's my patient. So there is your headline of the case. What are your initial thoughts and reactions? Do you see cases like this?
Yeah, absolutely. And they are really interesting and also quite challenging as well for many different reasons. Acute confusion or state or delirium can have so many causes. One cause can be multifactorial, and often really getting down to the nitty-gritty of what's causing that acute confusional state can be quite challenging. It's also difficult when you've got a history taken through a translator because you don't know how many things are lost in translation. And I think that's when our skill comes in then of observation and actually just observing the individual, observing the family dynamics, and also the real importance of physical examination and how valuable that can be as well. So, in front of me, I have a 63-year-old female. Any past medical history of note?
So the family say the only thing that she takes is a bit of, I think it was amlodipine for hypertension. That was the only medication and the only past medical history. Otherwise, she was a fit and well woman. She was retired. She was previously an administrative assistant. No great smoking or alcohol history at all. And she'd never had any kind of confusional state or psychiatric diagnosis made in her life.
I mean, first of all, I'd park the psychiatric diagnosis because, like the liaison psychiatrist said, you really need to rule out an organic cause. So I'm going to go back to basics here and try and think about what could cause an acute confusional state in a 63-year-old female. Now, you can use different mnemonics here. You can use like a surgical sieve, such as vitamin D, or you can look at the causes of delirium, which I use the mnemonic pinch me, and I'm going to talk through those now. So vitamin D, I'm thinking about vascular causes. So has this patient had an ischemic event, or is it a bleed? So a vascular event such as a bleed within the brain. potentially.
Okay. Yep. Yep. All right. So you're thinking maybe something like a spontaneous subdural hemorrhage. I've seen that before, actually, in a younger man who came in with what looked like a first episode of schizophrenia, paranoid delusion, psychosis,
Yeah.
and it was actually the CT head showed he had a big subdural hemorrhage, which I was
You
really
know,
shocked about.
I've had the same case as an F2. Isn't that strange? Exactly the same. I thought it was schizophrenia, psychosis, but it wasn't.
Mm.
Um, did have a history of schizophrenia in the background, but uh, okay. So the next thing I'm thinking about is infection. So infection can commonly cause acute confusional state. So I'd want to ask some infective-like symptoms, any pyrexia, any shortness of breath, cough, any headaches, any urinary symptoms, any gastroenterological symptoms. Could this be an encephalitis, a meningitis, or could it be urinary tract infection? Could it be gastroenteritis? So I'd really want to deep dive into all those different signs and symptoms. Trauma.
Sure, we'd absolutely do a septic screen, but just to interject quickly, don't you think that having a delirium due to an infection, which we do see very, very commonly in older adults, don't you think 63 is a bit young? A fit and well 63 lady who travels the world with no past medical history. Because you've got to have quite a vulnerable brain, don't you, for like a UTI to give you a delirium. I thought I was quite struck with how young and robust and not much past medical history. It'd be unusual for them to suddenly get a UTI, for example, and then go completely delirious with it. I mean, it could happen. But I remember thinking, gosh, the age
Yeah.
range is a bit odd for that.
Yeah, you're right. I mean, it is unusual. I have seen it, but certainly not as common as I've seen acute confusional state, secondary infection in people who are older in their 80s and 90s. Has she had any trauma? Has she had a fall? Has she banged her head? Anything like that?
Are you thinking of intracranial bleeds again?
Yeah.
Yeah. No, no, nothing like that.
No. Okay. Um, so check her blood sugar. It's really simple. Is she diabetic that we don't know about? Have we done a BM on her? Is she hypoglycemic? Is she hyperglycemic? So it's something that we can really think about very simply and identify
Blood
very
sugar
quickly.
normal.
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 Okay.
Yeah.
Um, so is she on any medication? Is she taking anything over the counter that we don't know about? You said amlodipine, but has she taken anything else that maybe could have contributed to it? Any painkillers? Any codeine-based products?
Nothing like that. No.
Okay. Um, I'm thinking about iatrogenic causes, metabolic causes. I'm thinking about neoplastic causes. Again, very acute. I have seen patients who do have an underlying brain malignancy present acutely with acute confusional state. So I'd certainly want to rule that out by doing a CT scan of the brain. Absolutely. But again, it's probably not high on my list of diagnoses at the moment. Is there anything that we've done to her, or, the iatrogenic causes that could have contributed to the delirium? Unlikely, as she's had it for 24 to 48 hours. And then medications, which we've talked about. Sorry, I know that's all over the place. I'm trying to gather my thoughts because it is quite a challenging diagnosis, acute confusional state. Is she in
Letting
pain?
you gather.
I know. Is she in pain?
Uh, no, but the thing is, it was so challenging because there was a total language barrier with a rather very fraught, understandably fraught family members translating. And this woman was not well. She was not in a place to be answering questions. In fact, she was trying to barricade herself into the corner of the bay and surround herself by tables next to the bed tables. She was shouting, she was screaming, she was obviously very afraid of something. And we couldn't really sit down and ask her a series of simple questions. The absolute heroicism of the emergency medicine team managed to get some baseline bloods and a CT brain. I don't know how they managed to do that, but other than that, it was absolutely, we couldn't even get her to sit or to get into the bed to examine her, let alone sort of ask more delicate questions to delineate a cause of acute delirium.
Okay. So I guess in this situation then, I guess you'd go back to basics and you'd do an A to E assessment and try and do an examination of as much as you can. you said that you've done some blood tests, some observations. Let's have a look at those. So, if you got the observations?
Yes, and I'm afraid they're not very exciting. Well, the blood pressure was 147/81. The heart rate was 91 beats per minute. The saturations were 97% on Romain. Respiratory rate was about 22, and her temperature was normal at 36.1.
Okay, so she's slightly tachypneic with a respiratory rate of 22, slightly higher than I'd like it to be. Um, so I guess I'd want to look at her. It sounds like it's probably not going to happen in arterial blood gas to look at her. Is she blowing off lots and lots of carbon dioxide? Is that why she's a respiratory rate's high? But it sounds like that's going to be quite difficult to get that.
Well,
So
yes, we got some venous bloods and we got a VBG that we ran off that, so we could see that her lactate
okay,
was normal, but she wasn't on the venous gas. And of course, you got to interpret this within that context of being venous. So the
absolutely.
COT will be higher, but it seemed to be about normal.
Okay, fine. Okay. Did you examine the patient? Did you find anything on clinical examination?
I gave it my best go, Amie, but
Okay.
it was tough. So she was obscene. Let's start with very basic examination. Observed ambulating independently around the room at
Yeah.
quite an agitated pace. There was no obvious problems with her walking, with her gait, and watching her moving around. I could not see very, very grossly. I couldn't see any sort of impairments of her motor function at all. Her family tell me that her speech was actually normal in terms of fluency, and she didn't seem to have any sort of expressive dysphasia, word finding difficulties. She seemed to understand what they were saying to her, but her thought processes were all over the place. Her fixations were very persecutory, that there was she was being imprisoned, that somebody was hunting her down, that she didn't recognize a lot of people, she did not agree that she was in a hospital, she did not see that we were doctors and nurses. She had given us the identity of, I don't know, some kind of villains who were holding her down and experimenting on her against her will. All extremely out of character stuff. Her family were very upset because they'd never seen their mum, their wife, ever act like this before. But that was the basis of my examination. She didn't seem to have any respiratory symptoms, and her family say there was no problems with sort of vomiting or diarrhea, no rashes anywhere. But that was really the limits of my examination.
Okay. So it sounds like then globally her neurological system is intact, i.e., that she's walking, which suggests that her power in her limbs is normal. Um, and it doesn't say that she favoured one side or the other, any weakness. So it sort of goes against this being a big infarct within the brain, doesn't fit that picture. Oh, gosh.
And also, how often do you see someone have a stroke, a cerebral infarctive stroke, and present with psychosis? I'm sure it could happen, but
Mm.
someone will say, "Oh, well, there's been this case report," but to me, people who have a stroke, they suddenly go paralyzed down one side, or they stop talking, or something like that. But you don't normally get acute psychosis that I've ever seen, and I can't really explain how that would work in terms of what area of the brain would they infarct for that to happen.
Did you notice any rashes?
No, and I had a look. Why are you asking about rashes out of curiosity?
Um, So, I mean, it's crazy. It's not meningitis. It's not going to be sepsis or meningococcal because she's too well in herself and her observations are fine. Are the rashes viral rashes? I'm stretching things now.
No, I did have a look for a viral reaction because you think about organic causes and um has she got lots of cold sores?
Yeah.
She got herpes simplex capsulitis, that sort of thing. But no, she didn't have any rashes.
Any purpura?
No.
So I was thinking thrombotic thrombocytopenic purpura can present with confusion.
It can, yeah, yeah.
I mean, that's quite, but mm, okay. Uh, any other rash? No, I think that's anything else you were thinking of from a rash perspective?
No, that was about it really. I mean, if she had an infection, then maybe that would manifest as a sort of dermatological eruption of some
Yeah.
description, but
Yeah, yeah.
no. And I was looking quite hard for infection. As I say, she was afebrile. Her blood test results, she had a CRP of 4, which is normal. Her white cells were normal at 9.1. Her neutrophils were normal. HB and platelets are both normal. And looking at her usernese, sodium was 139, potassium 4.7. That's both normal range. Urea was 3.1, creatinine was 63. That's normal range as well. So the bloods were absolutely completely bland.
Did you
So
do a thyroid function test?
not at that point, but I did put it on later.
Okay.
Yeah. So, and it did actually return as normal eventually, but that's a good thought. So what are you thinking about there?
I was just thinking of hyper or hypothyroidism. If it's really severe, can present with um, elements of confusion. So I'd really want to ensure that she has neither of those.
I remember when I was at med school, I was taught about a really harrowing case of a woman who had severe myxedema because of severe malignant hypothyroidism, who eventually developed a myxedemic coma, and how they described how she completely became delirious, was undressing, was breaking things at home, became colder and colder and colder. I've never seen it in my own practice, but it is something I always worry about and I always check.
Yeah, absolutely.
So if I
Okay.
tell you where I was at,
Yes, please.
yeah. So I was like, this woman is not well. She's either having an acute delirium due to an insult, which we mentioned. You can run through the pinch me acronym to do all the different causes of delirium. Um, Potentially, it was acute onset. But going against delirium, I just feel like you've got to have, as I said before, it's usually people who have got vulnerable brains who get a delirium. So when they get an insult, such as a severe infection or a metabolic disturbance, it can present as acute confusion. And she just seemed too young and too robust for that. And also, you do see a delirium presenting as acute psychosis, but a hyperactive delirium. But most of the time, hyperactive delirium, it just has a slightly different flavor to me. It tends to be disorientation and emotional dysregulation, the day-night sleep reversal, and to me, it just didn't smell right with the delirium that I see on a day-by-day basis. So delirium is one option. The other option I had was, is this pure psychiatry? Is this a first presentation of an acute psychotic episode? It looked psychotic. And I absolutely admit I'm not a psychiatrist, but all of these delusions of persecution, the paranoid aspect to it, someone's out to get me, the very florid nature of it, all these very odd ideas. Um, uh, her family was saying she thinks we're not real, and that's derealization, isn't it? Which you do see with psychiatric diagnoses. Um, but then I thought, why on earth would a 63-year-old woman get a first psychotic episode or de novo for no reason? Usually your first presentation of psychosis is much younger, in your 20s to 40s, whether it's an acute manic episode or a first presentation of schizophrenia. You get it out the way quite early now. So I thought that was odd. And so did the psych liaison team. And that's why they were saying, look, we don't make this diagnosis of the primary psychiatric until we've made sure it's not organic. So we get to organic. What could be an organic physical mental problem, which is causing this presentation? The one I always think about is encephalitis, viral encephalitis. So has she developed an acute infection, which has moved to this central nervous system, and it's caused inflammation of the brain? Much less common, a very rare diagnosis, but I do see it very now and again, which is autoimmune encephalitis. And you do see that in older people, and that can be due to autoimmunity, or it could be paraneoplastic. So if they have a malignancy diagnosed, undiagnosed elsewhere, they can get a paraneoplastic encephalitis due to that. So those are my two big organic ones. I've had the CT head in A&E, so I know that she hasn't had a big subdural hemorrhage, which is the other one I was thinking about, an intracranial some nastiness. And the other organic things I think about is severe electrolyte disturbances and hypoglycemia, like you mentioned, and I managed to take those all off the table as well. So here we are. So is it psychosis? Is it organic? Or is it a delirium? And now I've got to do some tests to work it out. And this is something that happens in acute medicine relatively frequently. You're tasked with getting some pretty important but pretty complex test results to look for organic disease. And then the logistical challenge of doing it on someone who is really confused and cannot comply with any of these tests that you want to do. So tests. What should you normally do in this situation?
So, gosh, this is a real difficult one, I have to say. So, you mentioned the pinch me mnemonic for causes of delirium. So, just going to recap on that. P is for pain, I is for infection, N is nutrition, C is constipation, H is hydration, M is medication, and E is environment. Could this all be environmental change?
What do you mean?
Well, she's travelled from Japan. She's been travelling in France and then Europe, then the UK. It's a big change. There's a lot of travel going on there. I mean, if I was to travel that much, I'd probably feel a little bit disorientated, but probably not that much. So that's just something that's in my background. I don't know. Um, so what tests am I going to do?
So we mentioned encephalitis as a potential, and the standard tests we do for those is obviously a lumbar puncture and an MRI. Now, I don't know if any of our listeners out there have ever tried to do a lumbar puncture or an MRI scan on someone who is literally trying to,
Mm,
barricade themselves into a corner of the room, is absolutely petrified out of their wits and believes you are some kind of torturer who's come to kill them or persecute them.
yeah,
But literally,
yeah, absolutely.
absolutely a nightmare
Mm,
to do safely. Now, you might say, well, just give them a bit of sedation and do it. But sedation is a tricky thing.
absolutely.
There's a whole branch of medicine dedicated to safe sedation. We call them anaesthetists. That's not their only job, obviously. They do many other important things, but we can't just bung someone some benzos and wait for them to get sleepy, then send them down to the scanner or roll them over and do a lumbar puncture on the ward. Because first of all, how are we going to administer those benzos? We can offer them orally and maybe they'll take them, but there's a very unpredictable onset and offset, and you don't really know how well they're going to metabolize and react to that. So offering someone, say, 5 milligrams of Valium or a milligram of lorazepam is a roulette wheel about what you're going to get out of that. And when you have got a MRI slot at 2 p.m. this afternoon, you getting the timings right, so they're just flat enough to have the scan, but still able to get on and out of the scanner. It's impossible, really. And then you say, well, why don't we give them something like a bit of IV Loraz or IV midazolam? At least that will sedate them well enough to do the lumbar puncture or do the MRI scan. And I'll say here and now, giving someone IV sedation, IV benzos, and then sending them away with a porter in a lift to the radiology department, which is an outpatient department, to lie around, wait for their turn, then go on MRI, come back, is an absolute recipe for disaster and is a very unsafe treatment for your patient. They are unfasted. They could easily vomit. They could aspirate. They could lose their airway. They could develop respiratory depression. The effect could be too strong and they might need some oxygen support. It could not be strong enough and they become psychotic and try to throttle the porter in the lift. But it's very, very, very unsafe. And I have had people suggest in the past, should we just give them some sedation and send them for the scan? At least it's done. And even saying, oh, I'll go with them as an escort. Like, but what are you going to do if they lose their airway in the corridor? You're going to take an airway bag with you. It's just really, really ropey. Similarly, giving someone sedation on the ward so you can roll them over and do an LP with a bit of oxygen on. Okay, it just makes me anxious. I find that's quite a risky way to do things. So very often when you want to get a lumbar puncture and an MRI for these patients, you're really liaising with your anesthetic colleagues who are on call and have hundreds of competing other duties to do. So trying to get an available anesthetic colleague to give safe sedation and airway management who is available to do so at the exact same time their MRI slot comes up or the rest of the team is ready to do a lumbar puncture is rarer than hen's teeth. I've never cracked that one. It's just not doable within the constraints of the NHS and how it functions. So what you end up doing if you really want these tests, a GA MRI and a GA lumbar puncture. Again, not for the weak trying to organize these two tests, because if the anaesthetists say, I'd like to facilitate, we do this on our CPOD list. Please come down at 7 a.m. in the morning to put them on the CPOD list and discuss with the team. But even more emergent case comes in, they'll fall off that list and we'll have to do a 7 a.m. thing the next morning. It eventually, in my experience, just does not happen. or the person who's meant to go down at 7 a.m. to discuss with these people gets called to a cardiac arrest, or they can't leave the ward. And the third option is sometimes they say, we can do it on a GA-guided MRI list. We do them on a Tuesday. We'll do it next Tuesday, which is great if it's Monday evening. But if it's Wednesday morning, then do you wait a week for this patient to have your test? Right, that's me talking a lot. And there's a lot of experience coming up there. But I really wanted to emphasize getting these really crucial tests
Yeah.
used to rule in or rule out organic disease for these patients who present with a first psychosis are logistically as close
Challenging.
as can be.
So I'm going to say something really controversial.
Go for it.
Do we have to do any tests?
Well, don't do anything we don't want to do, but we'll never know, Amy. We'll never know the diagnosis, no?
So, well, I'm just thinking, number one, I really want to understand what the family think. I know you said that they're quite distressed, but, really sit the family down in the family room and just get to the bottom of things and just say, what's going on? Is anything going on at home? What's been going on in your travels? How was she in Paris? And really take a thorough history from the family as much as you can. Say, what do you think's going on with your mom or your partner? That can help sometimes. Do nothing is always an option, and watch and wait. With delirium, we know that, or confusion, we know that A&E, where she is a very loud, very scary place. So the management of delirium, acute confusional state, primarily is put in a calm environment with good lighting, with people around you who maybe with your family in there to try and calm things down a little bit. So take away from the chaos of the emergency department can be helpful.
Mm.
So that's a possibility. Like you, I'm not a big fan of using sedation as a treatment, because I think that's more therapeutic for us. However, if she was a danger to herself or a danger to others around her, then that's when we may need to utilize some sort of sedation or some sort of mild antipsychotic, which you very rarely use in delirium if needed. So overall, when I get a case like this, I write in the notes. Do you know what I've discovered last week as well? How to dictate my notes on a dictaphone, and it types it directly onto the electronic patient record, which has literally changed my working day. But it does mean my notes now are like an essay. But that doesn't.
A stream of consciousness. Horrible insight into Amy's subconscious. We can do that, but I find it makes all the spelling mistakes. It can't spell medical terms.
Oh no, it does. It can.
Oh, maybe I need a new software package. If I said things like, encephalitic or a lumbar puncture or something, it would be spelling all sorts of disaster.
Oh no, it's so. What I would do now is I would do problem representation. I have a 63-year-old female who is a background history of hypertension, who takes amlodipine, who is fit and well, who's traveling from Japan, who presents with confusion, agitation, paranoid thoughts. Her observations are normal. Her investigations are normal. Her CT bed is normal. The most serious diagnosis I need to exclude here is a bleed on the brain, which I've excluded. I need to exclude an infection, such as encephalitis, meningitis. I can't exclude that without an LP, but her CRP is normal, white cell's normal, neutrophil's normal. I would have expected those to be abnormal if there was an infection. I'm going down my list of seriousness of causes. Could this be seizure activity? Potentially.
Oh, that's a good one. Yeah. Yeah. Oh, that's a good one, actually. And I forgot to mention, that's a really good test to do for when you're thinking about organic stuff.
Yes.
Are they having subclinical seizures? So doing an EEG as well as, hey, and an EEG is no easier than a lumbar puncture, an MRI if someone's floridly psychotic. But that's a really good addition to the screen.
Yeah, so that's something that you can think about, is, like you say, subclinical seizure activity, which can present like this. And subclinical seizure activity can also be a sign, I've seen it, of autoimmune encephalitis. So that may fit that. Again, very rapid onset. We've looked at her sugar, calcium levels, sodium, potassium, magnesium, B12, folate, thyroid. I mean, down the bottom of the causes is, could this be all environmental? Very busy, very exhausted, lots of travel, calm side room, allow her to sleep and watch and wait.
Do you know what, Amy? I really, really agree with that. And I said, and I had one of my fantastic FY1 saying, I've been on the phone, I've tried with the MRI and I need this. And I said, you know what, let's just park it for now. Um, Let her family think she's calmed down a bit. Let's see what things are like in the morning. She's in a safe place. She's on the ward. She's in hospital. Um, if your suspicion is strong about encephalitis, you can empirically start them on acyclovir whilst you're getting things ready. Acyclovir is used pretty safe. Sometimes it causes an AKI, so you have to keep an eye on their renal function. But most people, you can start it empirically whilst you're trying to get your ducks in a row. And let's see. And I mean, came in the next day, and her family said she's a little bit more settled. She seems to know she's in hospital now. We want to take her home. We've booked a flight to Japan this Friday. We've got to get her out of here. We think the hospital's making her worse. We really think she ought to go home. And she's starting to improve. And then you've got a little thought in your head about, is this a safe discharge? The patient doesn't have capacity to self-discharge herself. Can I let the family do it? And the family were not being obstructive or confrontational anyway. They were saying, please, can we take her home? We think this is the best way forward. And she was starting to improve. And that's when I had a little idea. It was an idea based on a diagnosis I remember reading about, probably at med school or when I was a very young doctor, which I've never made before. But I rang up the liaison psychiatry team again and said, we haven't done the MRI, the EEG, or the lumbar puncture. The patient seems to be improving now, and some of the psychosis seems to be melting away. In fact, she's now sitting there eating in her bed space, looking quite calm. I noticed that she came from Japan to Paris, then Paris to us 2 days ago. It might be unlikely, but could she have Paris syndrome? Have you ever heard of it?
No, I've never heard of.
So I was showing off a little bit to the FY1 I was working with.
Have you made this up?
No. And I said, you know what? And it's when I was reading her itinerary and it went, there's the Paris. I went, oh, I've heard of this before. I wonder if she's got Paris syndrome. I'm not brave enough to make that diagnosis, but if we can get the liaison psychiatry to come back and ask them that question, I'll dine out on this for the rest of my career. And the liaison psychiatry consultant actually came to see her, and they came and found me in the office afterwards. Went, oh, I've seen this lady, and I said to him, oh, brilliant, we think she's got Paris syndrome, and he said, oh yes, she does. And I'm going to tell you about Paris syndrome now.
Please do.
Yeah, it's so funny, and I never thought I would make this diagnosis in my life because it almost seems fictional. The Paris syndrome is a form of acute delusional state, mostly experienced by visitors from Japan when they come to the West. And it's thought to be a severe, extreme form of culture shock. And it isn't necessarily Japanese people coming just to Paris, but that's how it was first described in these people. But it can be anyone coming from one culture to another who then develops some very, very strange psychiatric symptoms. And it's classically, as I say, described with Japanese visitors to Paris. And the symptoms are acute confusional state, delusional states, feelings of persecution, feelings of derealization and depersonalization. It's always transient and it always improves. And as you said before, it would be the environmental cause.
Wow.
And the causes of it is meant to be, and I'm not going to offend anyone from the beautiful city of light from Paris, but it's meant to be a form of extreme disappointment. When visitors come and they find, and this is the index case in Paris, it's not what they thought it would be. Because sometimes these European Western cities are very idealized and romanticized in other cultures. They come here, experience profound jet lag, exhaustion, months and months of planning the trip, a very heightened sense of expectancy. And they come to visit a city, say Paris, and they find, oh, it's just an ordinary city. It's just people. There's rubbish on the streets. There's workers on the metro. It's just ordinary folk. It's raining. The culture's different. People don't treat people like in shops and in places as they do where I'm used to. I don't speak a word of the language. I feel very isolated. I don't understand how to order in restaurants. I don't understand what the system is in the supermarket. Um, and the causative, the cause are meant to be cultural differences, idealization of Paris when it does not live up to expectations, exhaustion, jet lag, and the language barrier. And it's actually a very well described symptom, which has been described. And it can be any city, could be London, could be Rome, anywhere where there's a high sense of romance and people coming from a very
Absolutely.
a different culture. Oh, Wolverhampton, I think this.
It's all right for
Uh, yes, even Wolverhampton. I'm sure it's very, very romanticized in Japanese culture. But I thought that was absolutely fascinating. And I remember reading about it thinking, that doesn't sound real, it sounds a bit made up to me, but it absolutely is real. And the timeline was perfect as well. 24 to 48 hours after visiting Paris, in the cases that you read online, when they start to develop these very, very odd symptoms, it always improves and they have to just go home. And was what my patient did eventually.
Wow. Wow.
And do you want to know something very interesting? I was doing some research about Paris syndrome. There's an opposite. There's an opposite called Florence syndrome, where people visit Florence and they can experience acute confusional states due to how beautiful it is, due to be overwhelmed by the beauty and the romance and the how gorgeous everything is, and it's more than they expected. And I thought, we went to Florence earlier this year. We did a podcast episode from the European Federation and conference in Florence, but neither of us got Florence syndrome.
But it was beautiful.
But it was very, very beautiful.
Yeah.
But there you go. So an ultimate diagnosis of Paris, and she didn't need those tests eventually. She didn't get the lumbar puncture. She didn't get the MRI. She felt well enough to go back to her hotel room, and her family took her on a plane and took her back to Japan. Now, I have no follow-up for this patient because obviously she's gone far away. But I thought it was a really interesting case because it talks about the difficulties of getting a test that are actually important at the point of ordering them. And sometimes doing nothing, as you say, and sort of saying, let's just see what happens here.
Yeah.
There's no rush. They're in a safe space.
Yeah.
We just need to, and it's worth mentioning, we have another 20, 30 patients we got to see today. We have to balance our time.
Of course.
We can't spend a whole day trying to organize these cases, and we have to see our other patients as well. What's the overall safest thing to do here that's just by everybody? And then I thought Paris syndrome was a nice little button to put on it, and maybe that's something people will remember now if they ever see it.
Absolutely. Thank you so much. So many learning points from there. Number 1, Paris syndrome. Number 2, Florence syndrome. Number 3, I think the beauty of this case is in the simplicity, in the way that sometimes watching and waiting is the best course of action, is the best investigation is to watch, and the best treatment is to wait. Now, I'm very pro watching and waiting and not doing many tests, which some people like, some people don't like. But again, I think in this case, if we'd done lots of investigations, it could have made her feel a little bit worse, actually, and contributed to the anxiety and the stress that she was undergoing. Thank you, Ben. Brilliant as ever.
Thank you.
So, our first episode at the Royal College of Physicians of Edinburgh. Thank you, Ben. I think that was a great episode to start with. And for all of you listeners out there, new ones and old ones, you will still be able to get us on all of your usual channels. Please rate, review and subscribe to the podcast, and we'll be back soon. Thanks for listening.